You listening? I know that I'm muted. Don't worry, we'll start after 5 minutes, okay? You see the presentation? Okay. After 5 minutes, we're waiting for another colleges and we'll start with the lecture, okay? Oh, see the presentation? See the presentation? Okay, are you here? Okay, let's start with the lecture. Only 21 of the students is here. Another, I don't know where is. Okay, about the error management. I sent you yesterday to lecture. Today I will send you another one. I told you last week that all of the questions about your exam is coming from my presentation and from the practical exercise with the another colleges of the uh, hospital. Okay, about the air management of the anesthesiologist, what is the important? Yes, the first one is important airway anatomy. About the term airway, refers to the upper airway, consists of the nasal oral cavities, pharynx, larynx, trachea, and principle of the bronchi. This is very important. Here you see in the picture, and I think that you know. For us, it's very important the anatomy of the larynx, anatomy of the nasopharynx when we are working with the general anesthesia, about tongue, about the oropharynx of the patient. Epiglottis is very important about the laryngoscopy. After that is coming because a lot of us working with the direct laryngoscopy to see the laryngoscopy view. You must know this picture because you have in your exam. What to see about the laryngoscope view? First one, we see the epiglottis. You can see here. Upper is the tongue of the mouth. After that, you can see the esophagus is down, and you don't put the intubation tube here. You must put in the intubation tube in the trachea. You can see the two white line. This is the vocal cord. You can see, and after that is coming the trachea. This is very, very important for all of the anesthesiologists and the laryngoscopy view because it is important to putting and insert the intubation tube in the patient and start with the general anesthesia. Okay, about the structure of the larynx and the carina, you see the laryngoscopic view. Here you have the another structure. After that, you know the bronch is coming left and right bronch. This is the general about after trachea is coming. And you what do you see about the routine airway management? First one is airway assessment, preparation and Egypt check. Patient position is very important for us and for the patient safety and for the working of the anesthesiology. After that is we are starting with the pre-oxygenation. We must have the bag or mask ventilation. Yes, intubation if you are working with the general anesthesia. After that is coming confirmation of the endotracheal tube placement, intraoperative management after that, and after the operation, it's coming to wake up the patient and extubate it in the operation table, in the operation room. Okay, about the airway assessment, what is the important? First one is the mouth opening. An incisor distance of 3 centimeter or greater is disabled in an adult. Upper lip bite test. The lower teeth are brought in the front of the upper teeth. The degree to which this can be done estimates the range of modulation of the temporomandibular joints. You know the Malampati classification. I told about this last week about the Malampati classification. You must know them. A frequently performed test that examines the size of the tongue in a relation to the oral cavity. The greater the tongue obstructs the view of the pharyngeal structure, and the more difficult intubation may be. Environmental distance, the distance between the mentum and the superior thyroid node, and the distance greater than 3 finger beats is desirable. Neck circumference is important when patient have some trauma, head trauma, and when the neck circumference is greater than 27, there is in the suggestive of the difficulties about the visualization, and we have the problem with the intubation and glottis opening. Here in this side, You see and know the classification of myelopathy again. We have the class 1 is the normal, complete visualization of the soft palate, and class 4 when we don't see invisible anything. This is the another class 2 and class 3 is important to myelopathy score for all of the patient. We making this test before starting of anesthesia one day when we are preparation the patient for the anesthesia and surgery operation. About the equipment in the operation, preparation is mandatory for airway management scenarios. The following equipment is routinely needed in airway management situation: oxygen source, back, laryngoscopy. Yes, we're working in with direct and video laryngoscopy, several endotracheal tubes of different sizes. Suction is very, very important when the patient is emergency or coming from the home or from some catastrophic oximetry and um, monitoring of the patient, stethoscope, tape, and blood pressure. Yes, it's about the monitoring of the patient. We have the special presentation and lecture about the monitoring the patient in the intraoperative period and post-operative. About the oral and nasal airways. Sorry. A loss of upper airway muscle tone in anesthetic patients allows the tongue and epiglottis to fall back against the posterior wall of the pharynx. Reposition the head or a jaw thrust for opening the airway. This is very, very important. To maintain the opening, and artificial airway can be inserted through the amount of nose to maintain in air passage between the tongue and the posterior pharyngeal wall. Awake or a lightly anesthetic patient with intact laryngeal reflex may cough or even develop laryngospasm during airway insertion. And about the oral and nasal airways, you can see in picture A and picture B. Here we're working with the oral airways, the special. You can see how to put the patient. You must know, all of the doctors must know how to put the oral or nasal airways in the lot of the situation and in the emergency room or when you're with the cardiologic or I don't know another specialist, you must know minimum how to put the oral airways in the patient of the all the patient of the doctors. And now about the face mask, I think that you see before in the another college clinics what do we have? Here we have the use of the face mask can facilitate delivery of oxygen for anesthesia gas or for CPR, cardiopulmonary resuscitation is very, very important about the breathing system. The rim of the mask is contoured and conforms to a variety of facial features you see about the nose and the mouth. And transparent masks allow observation of exhalated humidified gas and immediately the recognition of the vomitus. This is very, very important because when you're working with anesthesia, yes, a lot of patients, I told you last week that 12 hours before the operation, we told to the patient to stop eating food. 6 hours before the operation, they must stop it with drinking the water. This is very important preparation about the anesthesia. About the face mask, effective mask ventilation requires both a gastric mask fit and a patient airway. If the mask is held with the left hand, the right hand can be used to generate it positive pressure ventilation by squeezing the breathing back. The mask is held against the face by downward pressure on the mask body exerted by the left thumb and index finger. The middle and the ring finger grabs the mandible to facilitate extension of the atlanto-occipital joint. Finger pressure should be placed on the bony mandible and not on the soft tissue supporting the base of the tongue, which may obstruct the airway. The little finger is placed under the angle of the low, you can see here, and used to thrust the low anterior, the most important maneuver to allow the ventilation to the patient. Yes, you can see we're working with the left hand. I don't know, maybe you'll be in the operation room. We're working with the left hand. We check with the mask putting, and another hand, the right, is going to the back to make the positive pressure breathing to the patient. And about the breathing. About the position, when manipulation the airway, correct patient position is required. Relative alignment of the oral and pharyngeal axis of the chute by having the patient and sniffing position. When cervical spine pathology is suspected, the head must be kept in a neutral position during all of the airway manipulation. Patients with morbidity obesity should be positioned on a 30 degrees upward ramp as the functional residual capacity of the obesity patient deteriorates in the supine position, leading to more rapid deoxygenation should ventilation be impaired. About the pre-oxygenation, and other work is denitrogenation. You can see in your book is when is possible. Pre-oxygenation with face mask oxygen should be precede all airway management intervention. If you are working emergency patient about I don't know, maybe section caesarea or some trauma, you don't do pre-oxygenation in your patient. This is very big problem because when you're going to do pre-oxygenation, the some of the airway is going to the stomach and patient maybe start to vomiting. Oxygen is delivered by mask for several minutes prior to anesthetic induction. The functional residual capacity, the patient oxygen reserve, is per jet of the nitrogen. Increasing the duration of apnea, yes, about the normal oxygen demand of 200 to 250 milliliters per minute. The pre-oxygenated patient may have 5 to 8 oxygen reserve following apnea. This is very important for pre-oxygenation. About the increasing the duration of apnea without desaturation improves safety, and if a ventilation following anesthesia induction is delayed. Okay, about the back and mask ventilation is the first step in airway management in most situations, with the exception of the patient undergoing rapid sequence intubation. Rapid sequence induction avoid body back and mask ventilation to avoid stomach inflation and to reduce the potential for the aspiration of the gastric contents in non-fasted patient, and this with delayed gastric emptying. In emergency situation, we don't do this ventilation procedure. Attempts and intubation in afford to oxygenate the patient with the understanding that there is an implicit risk of aspiration. If the airway is patient, squeezing the bag will result in rise of the chest. If ventilation is ineffective, no sign of chest rising, no end tidal of the carbon dioxide detected, no mist in the clear mask, oral or nasal always airways can be placed to relieve airway obstruction secondary to redundant pharyngeal disease. In years past, anesthesists were routinely delivered solely by mask administration. In the recent decades, a variety of supraglottis devices has permitted both airways rescue. With back and mask ventilation is not possible, and routine anesthetics airway management with intubation is to be necessary. One of the best maybe anesthesia, laryngeal mask airways. Laryngeal mask is composed of a small mask designed to sit in the hypopharynx with anterior surface aperture overlaying in the laryngeal inlet. Laryngeal mask airways consist of a wide bore tube whose proximal end connects to a breathing circuit with a standard 50 milliliters connector, and whose distal end is attached to an elliptical cuff that can be inflated through a pilot tube. In the right of the presentation, you can see the different mask size in the adult patient, larger adult, who have higher of 17 kilogram. We're working with the mask size 5. And for the infant patient, we work with the mask size 1. This is the difference, and only this mask size we have to the patient about the laryngeal mask airway. About the laryngeal mask airway, protect the larynx from pharyngeal secretion, but not gastric regurgitation. And it should remain in place until the patient has regained airways reflex. This is usually signaled by coughing and mouth opening in common. The laryngeal mask is available in many sizes. You see the sizes of the laryngeal mask. Very important. Contraindication included poor lung compliance or high airway resistant. This is patient with COVID-19. We don't working with the laryngeal mask. Glottis or supraglottis airway obstruction for maybe allergical reaction or something else. And the limited mouth opening is very, very contraindication for the laryngeal mask patient. Relative contraindication for the laryngeal mask anesthesia included patients with pharyngeal pathology, for example, abscess or some pharyngeal problem or some genetic problem. Full stomach is the relative contraindication, and about that, we don't working with the laryngeal mask in the 6 area in the patient who is pregnant. Hiatal hernia or low pulmonary complication, for example, restrictive airway disease and peak inspiratory pressure greater than 30 centimeter of the water. About the insertion, how to put, this is the laryngeal mask. You can see in the picture what is the important. First one, you must putting something to the laryngeal mask. We're working with the lidocaine cream. After that, we find how to find your pencil is putting with the two fingers is catch your laryngeal mask, open the mouth of the patient, and putting with all of your sila in the laryngeal. And after that, it's coming to cuff the balloon. This is very important. Inflate it the correct arm of the air and to find the position of the patient. This laryngeal mask with the balloon, the new one of the maybe last 5 years, we are working with the iGel laryngeal mask. Just a second to see. No, we don't have here in the presentation. Sorry, I will send you the picture. It's the special because it is a medical silicone, and the iGel mask is very better because they don't have the balloon, and it's very natural and anatomic. The mask is very natural and anatomic when you're putting in the mouth to the patient about the laryngeal mask anesthesia. About the esophageal tracheal combi tube, this is the combination with two tube in one, esophageal tube and the tracheal tube. First one of the tube is going to the esophagus. When you cuff the balloon, is stopped and close the esophagus. Another one of the tube is going to the trachea. The longer blue tube has a occluded distal tip and forces gas to exit through a series of side perforation. The shorter, clear tube has open tip and no side perforation. The combi tube is usually inserted to the mount and advanced until two black rings on the shafts lie between the upper and lower teeth. About the because we have the two inflated cuff, 100 milliliters proximal cuff and 50 milliliters distal cuff. This is very important because the rhinopharyngos is larger diameter and the trachea diameter is very, very small. About this, when you're working with intubation or conti tube trachea, we are putting 50 milliliters about the distal cuff, the tube who is going to the trachea. The distal lumen of the combi tube usually comes to lie in the esophagus approximately 95% of the times, so that in ventilation to the longer blue tube will force gas out of the side perforation and into the larynx. Yes, this is the kind laryngeal tube. Is very very big. Is the tube? All of this tube. We are anesthesiologists. We don't work with conduit tube and with the king laryngeal tube. This is the tube for the people who is working in the emergency room, people who have in the ambulance car, who have the emergency situation and must doing something, but they don't know how to intubate the patient. About the king laryngeal tubes, is the tube with small esophageal balloon and larger balloon for the placement in the hypopharynx. You can see here one of the balloon is going to the esophagus down of the tube, and the bigger is coming for the hypopharynx to close the esophagus and open the trachea. The laryngeal tube is inserted and cuff is inflated. After that, should ventilation prove difficult, it's likely inserted too deep, slightly withdrawing the device until complications improves, ameliorates the situation. And yes, the laugh of us of the anesthesiologist endotracheal intubation or is oropharyngeal or nasopharyngeal about the intubation. What is the important? Endotracheal intubation is employed both for the conduct of general anesthesia and to facilitate the ventilatory management of the critical air. Tracheal tubes are most commonly made from polyvinyl chloride. The patient's end of the tube is related to aid visualization and insertion to the vocal cords. Murphy tubes have a hole, Murphy eye, to decrease the risk of conclusion should the distal tube opening about the carina or trachea. About the trachea sizes of the intubation tube, usually designed in millimeters of internal diameter, or less commonly in the French scale, external diameter in milliliter multiplied by 3. Yes, here is the Murphy eye. You can see opening the tube, about the cuff and the balloon when you can, this is the valve and pivot balloon. You inflate it with the air tube, and here is going up the cuff is carrying the tube. Another is connector. This connector will connection with the um, anesthetic machine to give the patient the air and some anesthesia gas. Here you can see the how to know what type of the size of the patient to give. Uh, the standards in the medicine is that the male working with 75 to 90 millimeters of the intubation tube, and about the female is between 6 to 75 millimeter internal diameter to the intubation tube. This is the sizes of the intubation tube. In the child is very very different. Child anesthesia, infant anesthesia is very very different between the adult general anesthesia. Yes, what we do, we have modified it for a variety of the specialization application. We have this flexible intubation tube, spiral wound. We have the armored tubes, microlaryngeal tubes, double lumen endotracheal tubes with a double lumen. We are working when patient have some lung transplantation, when we must isolate it, one of the lung ventilation, or patient with some carcinoma in the lung carcinoma, and another situation when we must isolate it, the lung and stop one lung ventilation. Yes, we have the special bronchial blockers. Is the another modified intubation tube, and the metal tubes designed for laser airway surgery to reduce fire hazards. And the special another NEPA is for the head and neck surgery. For the oral nasal is the curved uh, tubes for the this operation. And what is the laryngoscope? Laryngoscope is very important instrument who is important when you are working general anesthesia, not only one general anesthesia, you must have in your anesthesia operation room. Used to examine the larynx, a laryngoscope view, and to facilitate the intubation of the trachea. The handle usually have the batteries to light a bulb. This is the bulb you can see uh, in the blades of the laryngoscope. This is the blades. You can see we have two different blades. One is the Macintosh and another one is the Miller blades. What is the difference? Is the difference we are working with one of them in the adult, in the another with in the child. In the Macintosh, you can see is the curve blade. About the Miller is the one size mill. Another one is the Wisconsin, but for you it's not important to know. This is for the specializing when you start specializing them anesthesiologist or intensive care. And the best one for the not only for the COVID-19, for all the patients is video laryngoscope. Video laryngoscope is the optical special laryngoscope have a video chip or lens at the tip of the intubation blade to transmit view of the glottis operation. The device is different, the angulation of the blade, the presence of the channel to guide the tube of the glottis, and single use or multi-use nature of the device. Video or indirect laryngoscopy is another name, most likely offers minimal advantage in the patient with the uncomplicated airways. And yes, all of the patient from the COVID-19 pandemic, we are in our hospital working only with the video laryngoscopic. You know the effects of the COVID about infection, and it's very important for the anesthesiologist to do not have the direct contact with the patient who must intubated. About this, to be working with the video laryngoscopic and not with the direct video laryngoscopic. You must know that we have the difference between the video and direct laryngoscopy. In the video laryngoscopy, we see the laryngoscope view in the monitor. When we are working with a laryngoscope, we have the direct laryngoscopic view with our eye. In the video laryngoscopic, the laryngoscopic view is in the monitor. You don't put in your eye in the mouth of the patient. Yes, this is in the left side is fast track, special instrument, special for laryngoscope is the plastic. You can see the tube is putting in the machine. You open the mouth of the patient, putting the machine, and the intubation tube is going there. This is the special fibroscopic laryngoscope. About the flexible fibroscopic, fiber optic, so sorry, bronchoscopes. Um, Flexible bronchoscopes may be fiber optic, video, or hybrid systems. A lot of them is a lot of the hospital in Bulgaria have the fiber optic or video bronchoscopes. Is some of the hospital who is working with a very big patient pulmonary system. Yes, have hybrid systems. What is the uses of the bronchoscopes? Diagnosis, first one. Another one is diagnosis disease of the tracheal bronchial tree. And for us, for the anesthesiologist, it's important for the difficult intubation. For example, awake bronchial fiber optic intubation, suction of secretion of blood or from the airways. When we are making lung transplant in hospital, guide placement of the percutaneous tracheostomy, double lumen tube or bronchial blockers, and endotracheal
bronchial valves. Treatment of um, special disorders in the intubation in the sorry in ICU, intensive care unit, about the bleeding or some special problem. This is the bronchoscope. I think that in the May we opened the simulation center in our hospital because I'm in the team. And if we are open May, maybe you have the first students who will come to the practical exercise in our simulation center. You are working, we are intubated the mannequin, you are working with the bronchoscope and bronchoscope view. We are talking all of them in the mannequins. I think that in the May, maybe before 6th of the May, we open the simulation center, but I don't know. I'm waiting the last uh, preparation for the simulation center. Okay, about the bronchoscope, here is the control section. Here is the special blue up of the distal end. Here we have the channel outlet about the light lens and objective lens who is coming. Bending section, insert tension tube is coming from here. And after that you have the eye spices or here monitoring the special machine, and you have the view in the monitored uh, patient with the bronchoscopy. About the direct and indirect laryngoscopy intubation, insertion of a tube into the trachea has become a routine part of delivering a general anesthesia. All the time when we are working general anesthesia, we are working with the endotracheal intubation. We don't working without intubation. Intubation is not a risk-free procedure, and none of the patients receiving general anesthesia required it. A tracheal tube is generally placed to protect the airway and for airway access. Intubation is indicated in patients who are at risk of aspiration and in those undergoing big surgical procedures. Preparation for the direct laryngoscopy is included checking the equipment and property position of the patient. You must check the intubation tube about the cuff. It's very, very, very important to test by inflating the cuff using a 10 milliliter syringe. It's very important because if the cuff is not working, yes, you're putting here and intubated your patient. After 5 minutes, intubation tube is going out, and you have the problem. Patient is going dead. If a stylet is used, it should be inserted into the tracheal tube, which is then bent to resemble a hockey stick. Okay, successful. How to know is the correct position? First one, successful intubation often depends on the correct patient's position. The patient's head should be level with the anesthesiologist's waist or higher to prevent unnecessary back strain during laryngoscopy. Direct laryngoscopy displaces pharyngeal self-tethesis to create a direct line of vision from the mouth to the glottis opening. Preparation for inducation and intubation also involves routine pre-oxygenation. Because general anesthesia abolishes the protective corneal reflex, care must be taken during this period not to injure the patient's eyes. The goals of the tracheal intubation are to place the intubation tube in the trachea and the position of the tube at the proper depth inside the trachea, not before the trachea, inside the trachea. This is very important because a lot of the students, not only students, doctors who is starting with the studying anesthesiology and intensive care specializing, they are putting the and insert the intubation tube, but not insert in the trachea. And what happened? The cuff is coming to the vocal hold. They cuffed, and after that, here we have the trauma in the vocal cord after operation in the patient. This is very important to know about the position of the intubation. Here is the position of the sniffing position and intubation with the Macintosh blade. You can see the Macintosh blade is coming before the epiglottis. When we are working with with the Mueller blade, Mueller blade end is going after the epiglottis, is going here. When we are working with the Macintosh, the end of the blade is coming before the epiglottis. After that, your hand is going up and across. You can see the black streak of the picture. And what happened? Again, we have you must when you're working with the director laryngoscopy, see laryngoscopic view to see the vocal cord fold of the patient. After that, we are putting the intubation into tracheal tube. We are intubating the patient. Again, the cuff must going after vocal cord, not before, not in the vocal cord, after vocal cord in the patient. Okay, with the left hand we are hold the laryngoscopy. With the right hand we are insert the intubation tube. When you can see here, the cuff is after vocal cord, the intubation tube. After you're putting and insert correctly the intubation tube, you are going to inflate the balloon. Yes, this is the difference I told you about the difference between the curved blade about the Macintosh and the straight blade about the Mueller. I told you the difference what is. The first one, the curved blade, the end of the blade is coming before the epiglottis. You can see here. You can. This is the vallecula of the epiglottis. This is the white one is the epiglottis you can see in the picture, and this is the very important. But if you are working with the straight blade or Mueller laryngoscope blade, about this vallecula is here, and the end of the straight blade is going after vallecula, after epiglottis. You catch and uh, epiglottis. When we are working with the curved blade, the end of the laryngoscope blade is coming before epiglottis, before vallecula of the laryngoscope. Okay, nasotracheal intubation. If the some of the doctors is working in the mount operation or something different, we are working with the nasal intubation, and the little child, we are working with nasal intubation. It's a similar to oral intubation, expect that the tracheal tube is important to put it into oropharynx before laryngoscopy. Yes, about the what is the difference between oral? One intubation tube is coming from the oral. You can see from the nasal is coming from the nasal intubation. Is all of the patient we are working with the oral intubation is better because the nose is very small sizes. Okay, how to know that you're in the correct position and your endotracheal tube is in the trachea. First one, you have the direct visualization of the laryngoscopy. First one, in just a second. Yes, here in the picture, you see the vocal hold, you see the intubation tube, and your insert. You have the direct visualization of the oral and about the intubation tube. Second one, about the verification of the endotracheal tube is capnography. This is the picture of the normal capnography that your tube is the correct position. After that is coming auscultation. Yes, you must auscultate it from left side and from the right side. And if you're put maybe 30 centimeter of the endotracheal tube in the trachea, you don't have the left side breathing. You have only the left side. Why? Students, Why, if you're putting endotracheal tube 30 centimeter inside to the trachea, we don't have the breathing left side, only right side we have the breathing. What do you think? Mhm. Talking. Why do not talk? What is the anatomy difference? Yes, because yes, is we have the difference between the bifurcation, yes, the right brain has straight, and the intubation tube, yes, the right main bronchus. Intubation tube is going to the main of the trachea and block it, stop working the right bronch. Okay, and yes, another one of the verification is X-ray, but with X-ray only in the patient who is going to the ICU. You can see in the picture here is the verification of the intubation tube. And now, because we are working, because I'm of the one of the ultrasound intensive care certificate in our hospital, another one is the ultrasound lung ultrasound identification about the intubation tube. Okay, and what is the critical thyroidotomy? This is the emergency and very important procedure. If you have edema of Quincke, do you know what is the edema of Quincke? Hmm? Are you not talking? Yes, what is Matis, Michalis, sorry. When you have edema of Quincke, turn on your microphone. Hmm.
Hello, doctor. Can you hear me?
Yeah.
Yeah, quick edema is when there is obstruction or a foreign body in the throat.
Yes, but in what type of the what is the problem with this patient when you have the edema of Quincke?
The problem, you mean, there is swelling basically of the
Mm-hmm.
lower skin.
Mm-hmm.
The, sorry?
Yeah, yeah.
Yeah. And there is, it is related to allergic reaction when,
Yes,
or it is based on food,
yes.
for
This is
example.
allergic reaction. Yes, yes, yes. It's very important. About this is very must to know how to doing the cricothyroidotomy. Yes, you see in the your movie or but it's very important emergency procedure that is used to obtain in airway when the other more routine methods for the laryngeal mask or intubation tube is ineffective and contraindicated. The procedure you must first one you can see in the practical exercise percutaneous cricoidotomy is the difference because if you have the patient with the carcinoma in the trachea or something else, we don't do it percutaneous cricoidotomy. We are doing the surgical cricothyroidotomy. About the problems, you can see the practicals because I have the mannequins. I show you practical how to do, and you are doing the first in the mannequins, not in the patient, cricothyroidotomy to the patient, to the our patient in the simulation center. About the problems following intubation, first, yes, is the not position good about the esophageal or intubation. You're intubated the esophagus or bronchial intubation or laryngeal cuff position. Another one is airway trauma, dental damages. Is very if you have patient with some parodontosis or something else. If you have the lip, tongue, or mucosal laceration, patient with the woman with the dermal and plastic surgery is very important to don't do it the airway trauma about the lip. Um, we have the hypoxia, hypercarbia, but is the difference we are talking about this laryngospasm is one of the problems who is coming before extubated the patient. Malposition, unilateral intubation, and another is the ulceration or cough when you're putting the lot of not putting 10 milliliters air in the cuff, you're putting 15 or 20 milliliter, you may be the rupture the trachea. This is another one of the problems following the intubation. About the extubation, yes. So now you are talking the intubation, now about the extubation. About the extubation, first one should be performed when the patient is either deeply anesthesied or awake. In either cases, adequate recovery from neuromuscular blocking agents should be established prior to extubation. Extubation during a light plane of anesthesia, because you have the increased risk of laryngospasm. This is for the child and for the infant patient. Extubation in an awake patient is usually associated with coating, booking of the tracheal tube, and the presence of the tracheal tube in an awake asthmatic patient may trigger bronchospasm. You must know before extubated your patient. You ventilate it with 100% of the oxygen in case it becomes difficult to establish airway after the tracheal tube is removed. Or if you have patient with some myelopathy 4 or some problems about the intubation, first one you're ventilated with 100 oxygen. After that, waiting for the 5 to 8 minutes, you have pre-oxygenation, and after that you are extubated your and remove your tube of the your patient of extubated, because you have the time. If you must put in again intubated the patient, you have the time and you don't have the desaturation and low oxygen. Okay, sorry. Okay, technique for the airway management of the patient with suspected spinal cord injury is better. First, the nurse or another colleagues is putting the hand of the head of the patient. The neutral position is very, very important. Anesthesiologist, another one, is the center of the patient, and uh, take the laryngoscopy, and another colleges is give the intubation tube to intubated the patient. This is very, very important. Neutral position of the patient with suspectical injury for the head or for the neck. About the complication of, you can see here, we have the difference about extubated, vocal cord motion, anterior exertion surgery is different, and because laryngospasm is the very, very important problem when we are extubated your patient, how to know patient is vocal cord is closed, the larynx cord is closed, and patient is fission, so is not taking the air. Includes removal of opening stimulus. First one, removal the secretion. After that, continuous positive airway pressure. Take your mask, putting in the mouth of the patient, and starting with your right hand in the back. You see it at the first of this presentation when we are talking with the back ventilation. We are starting with the continuous positive airway pressure. Another one is to give a rapid acting muscle relaxant, succinylcholine. We are talking about the muscle relaxant maybe next week or after that. If they are no contraindicated, patient does not have the full stomach or other respiration risk, mask ventilation can be technique employed for the duration of anesthesia maintenance. Otherwise, it is commonly used to administered anesthetic gases until the anesthetic state is adequate for the use of another means or airway support. Yes, this decision is made after careful consideration of the patient's coexisting disease and surgical requirements. Okay, this is for today. Just a second, don't close the users because I like to save your username. Yes, I saved. Thank you. Do you have some question? If you don't have some question, next week you'll see again maybe I will send you the information, send my presentation for today, and I will write you because you know the about COVID-19 situation now is good, and all of the lecture is starting to be in the hospital. But if you like, you're making our lecture online only, but don't talk to the dean or to Maria Nacho because you're making the mic problem to me and for you. Okay. Have a good night. I'm going to drink some coffee and start to learning for tomorrow. Yes, doctor, when to decide to use the Macintosh in just a second, you have some questions, just a second to see. Everything is clear, thank you very much, okay. I will send you, don't write, don't make a recording about my lecture, I will send you. This is not, thank you very much, okay. Yes, doctor, when do you decide to use the Macintosh? Aha, or Mueller. A lot of the anesthesiologists, we are working with the Macintosh because it's better, because it's coming before the epiglottis. You catch the epiglottis and epiglottis is going up. But in the child, we are working with the Mueller because the tongue is very big and the epiglottis is very big. In the adult, epiglottis is smaller than in tongue is the smaller, but in the child, in tongue and epiglottis is very, very big. Maybe I will making, if you like, one lecture for the anesthesia in the child, who is the difference, because in the child we have a lot of difference between child and adults, and in the patient with in the adult patient we are working with the Macintosh. With Mueller we are working only in the small patients, so sorry, in the child and infants. Hassan, thank you. Okay, just a second, have a nice good night. Okay, see you, bye bye.
Bye, doctor.
About the practical exercise, you don't told me. What do you have practical exercise? Because if you don't have, I will coming to. You have.
Yes, doctor, we started.
Okay, with Dr. Vladimirova, Dr. Dimitrov, or Dr. Mutafov or Baurensky?
We have Dr. Vladimirova now. I don't know for the rest of the groups.
Okay, Dr. Dimitrov. Okay, Dr. Dimitrov, a lot of you with Dr. Dimitrov, yeah, you're going to the operation room, yeah? Or no? You see the operation? We did once, yes. Yes.
We did your doctor, sorry.
Okay. See you. Bye bye.
You are currently the only person in this conference.